So, Steve, thanks very much for that invitation, for that introduction, and for the invitation to come out for a visit. I had a really nice time meeting with a number of members of the department yesterday, and giving the Pecoraro lecture last night. So, before I get started, let me just make a couple of disclosures. First, as Steve mentioned, I have a R18 award from the NHLBI to study the use of non-invasive ventilation in COPD. I'm going to be talking a little bit about that today. And also a subcontract, I've done work with the folks, Harlan Krumholtz's group at Yale, to develop hospital outcome measures for patients with COPD. And I will bring that up during this morning's talk as well. So I want to start off, though, with a case. And we often review cases of patients who are readmitted at our hospital. And so this readmission M&M was a 62-year-old with hypertension, diabetes, and heart failure who was readmitted to the medicine service with a recurrent exacerbation of COPD. She had been hospitalized about a month earlier for COPD and had a fairly complicated course. She was initially admitted to a ward bed and begun on bronchodilators, steroids, antibiotics, the usual stuff. She deteriorated and was transferred to the ICU and was intubated on the second hospital day. Fortunately, she only spent a few days on the ventilator and was extubated, but developed diarrhea from C. diff, which prolonged her stay even further. And she was ultimately discharged home on day 10. So let's keep that case in mind. And in terms of today's talk, what I'm going to start off with is putting hospitalizations for COPD in the context of what we know about hospitalizations for other conditions and for COPD itself. I'll highlight current guideline recommendations, review some of the evidence behind that, as well as some emerging evidence that we and others have contributed to. The third section, I'll take a look at what we know about the quality of care for patients hospitalized for COPD. And then lastly, I'll close with a section on what I think are some promising strategies to improve patient outcomes that you can consider incorporating into your practice and building into your system here. So COPD is an enormous problem in the United States and worldwide. We know from the Behavioral Risk Factors Surveillance Survey and other sources that as many as 15 million U.S. adults, 6.5% of the population, have been told by a physician that they have COPD. And some estimates put this number as high as 24 million. These patients make 1.5 million visits to emergency departments each year, 800,000 annual hospitalizations. We can thank David O. For clarifying that for us in a paper a couple of years ago. The inpatient mortality rates are between 2 and 5%, and 30-day mortality rates are up to 8%. And like many conditions that we treat in elderly patients in the hospital, this one is associated with a high rate of readmission. As in the case we started with, 1 in 5 patients can be expected to come back to the hospital within 30 days. The direct costs alone have been estimated at $30 billion. Most of that is due to exacerbations, 70% of those costs. And total costs, including all the indirects, exceed $60 billion. So in the face of declining mortality rates for heart disease, to some extent cancer, and certainly stroke, COPD has emerged as the third leading cause of death in the U.S. in the last couple of years. I'm talking about COPD today, but this slide is just to remind us that the consequences of tobacco are far broader reaching, both here and worldwide. This appeared in our local small town newspaper just a couple of weeks ago, and I couldn't resist sharing it with you. And in addition to thinking about COPD as a cause of death, keep in mind that it has really substantial effects on the quality of life of patients. And repeated exacerbations, the kinds of exacerbations that result in hospitalization, accelerate the rate of decline of FEV1 and quality of life. And so thinking about the prevention of exacerbations and the prevention of recurrent exacerbations is a really important part of care. And this figure uses data from AHRQ's Healthcare Cost and Utilization Project to highlight the annual number of admissions for the 5 leading causes of hospitalization in the U.S. And as you can see here, COPD ranks only behind pneumonia and heart failure, and ahead of acute MI and stroke as a leading source of admission. I don't have a slide about this, but an interesting thing about COPD, more so than these other conditions, is that there's quite a bit of regional variation in rates that obviously is tied to variation in the incidence of smoking and the past incidence of smoking. And Washington State, I looked at the map, has actually got a somewhat lower incidence of COPD than other states in the country. Obviously, the tobacco belt is in the lead there. So with one exception, each of the conditions that I highlighted on that last slide has really benefited from extensive national efforts to improve quality of care. So pneumonia, heart failure, AMI, stroke, there are registries, the NCDR registries being a good example. Get with the guidelines for AMI, heart failure, and stroke, but led by AHA, the Joint Commission's core measure program, public reporting of hospital outcomes, and pay for performance. On the other hand, COPD has really been sort of disproportionately neglected in the realm of sort of important hospital conditions. But the good news is that the landscape is beginning to change. So CMS recently announced its intention to add measures of hospital 30-day mortality and 30-day readmission to the existing public reporting websites. And COPD was highlighted in the Affordable Care Act and in the Federal Register for being added to the hospital readmission reduction program, the one that applies penalties to hospitals with high readmission rates. And both of those are going to be kicking in later this year. Okay, so I'm going to switch gears now and highlight a few of the key guideline recommendations and the evidence and emerging evidence around them. And so let me go back to a case and have some audience participation here. So this is a 62-year-old woman with a past medical history of hypertension, diabetes, heart failure, and COPD. She's admitted with several days of worsening shortness of breath, purulent sputum, mild hypoxia. And upon admission, you order oxygen, a short-acting bronchodilator, and antibiotic therapy. As usually happens, Solumedrol 125 milligrams is administered in the emergency department. And so a show of hands, how many of you would like to continue methylprednisolone at 125 Q6 for a few days, then switch over to oral prednisone, and then give a 1-week taper? Show of hands for this choice? Okay, not so many. How about start prednisone 40 milligrams daily by mouth for a week and then a 1-week taper? We have a few brave souls. Start prednisone 40 milligrams daily by mouth for 5 days. Oh my goodness, everybody is so smart here. And then discontinue systemic steroids. Begin an inhaled corticosteroid. No, okay. We actually have done some research looking at the use of inhaled steroids. About half the patients get put on them or continued in the hospital, even when they're given systemic steroids. So you guys are even ahead of the guidelines. Okay, you're like right on the cutting edge. So the guidelines, which were updated in 2013, say this: systemic steroids shorten recovery, improve lung function, arterial hypoxemia, reduce the risk of early relapse, treatment failure, and length of stay. And a dose of 30 to 40 milligrams of prednisone for 10 to 14 days is recommended. And this VA study published in the late 1990s, really had a major influence on care in the United States for quite a while. This was a multi-center RCT in which patients were randomized to either placebo or two different courses of systemic steroids. One beginning with this 125 milligrams every 6 hours for 3 days, followed by a prednisone taper that either lasted 2 weeks or 4 weeks. And as you can see here in the Kaplan-Meier figure on the left, that the incidence of treatment failure was reduced in both steroid-treated groups without any benefit for the prolonged course of steroids. And, for many years, I think this was the dominant sort of treatment paradigm, despite guideline recommendations that actually promoted shorter, lower doses of orally administered steroids. And my own observations in years past was that it really seemed that physicians, as I said, were not so much following the guideline recommendations, but were influenced by the VA multi-center study. And I was interested in studying this and was able to take advantage of a large data set that captures detailed information from 400 or so hospitals on all of the treatments that they received during their hospitalization. And in this study we published in JAMA in 2010, we analyzed the records of about 80,000 patients who were admitted for COPD exacerbations and looked at the association between steroid dosing and a composite measure of treatment failure, which we defined as needing to be intubated after an initial admission to a regular bed, death, or readmission. And using propensity and instrumental variable methods, what we found was that patients who were treated with low doses of steroids, which was only 10% of this sample, and these were data from 2007 through 2009. So 2007 through 2009, 90% of the patients were getting high-dose IV steroids over the first few days, average doses of around 600 milligrams of prednisone equivalent. 10% of them got these low-dose oral, strategies of about 60 milligrams a day. Overall, the composite treatment failure rate was about 11%, and in these, there was really no benefit for high-dose steroids that we were able to detect. And patients who got treated with high-dose steroids tended to have somewhat longer length of stay and higher hospital costs as well. So that was interesting, and it seemed to support the guidelines as they were written. But I think the most significant study to date, and perhaps what led to the responses from the audience this morning, was the REDUCE trial that was published this past year in JAMA that compared short-term versus conventional dosing, the 2-week dosing of PO steroids. This was a multi-center non-inferiority RCT carried out over 5 years at 300 at a number of centers. It included 314 patients who presented to the ED with an exacerbation, of whom about 90% were ultimately admitted to the hospital, and they were randomized to 40 milligrams of prednisone for 5 days or 14 days. The main outcome in this study was time to the next exacerbation, and their predefined non-inferiority criterion was an absolute increase in exacerbations of at most 15% associated with the shorter course of treatment. You can see here that in terms of the outcome of time to re-exacerbation, looking out to 6 months, there was no difference between the two groups. The same held true for the survival outcome out to 6 months, and even FEV1 measures were similar. So, coming back to our case, I think given the results of the REDUCE study, it would be reasonable now to just start prednisone 40 milligrams for 5 days. So you guys give yourself a check mark for getting this question right. So with regard to antibiotics, the GOLD guidelines make the following recommendation. Antibiotics should be given to patients with exacerbations of COPD who have 3 cardinal symptoms, that is increase in dyspnea, sputum volume, and sputum purulence. That gets a evidence B rating. Have 2 of the cardinal symptoms. If purulence is one of them, that's an evidence C, or require mechanical ventilation, a B grade. And the recommended length of antibiotic therapy is 5 to 10 days. The guidelines are less clear about what antibiotics actually should be given. As you can see here, the number of RCTs upon which this recommendation is based is remarkably small. And Actually, several of the studies are approaching 50 years old. And only a few of them actually included hospitalized patients, and most were conducted before steroids were routinely administered to patients at the time of a COPD exacerbation. So with that in mind, we were interested in revisiting this issue in a contemporary cohort of hospitalized patients. And using the same data set that I mentioned earlier, my colleague Michael Rothberg and I carried out a retrospective cohort study of patients who were hospitalized, again, for COPD at 400 or so hospitals in this network. And we analyzed the association between treatment with antibiotics at the time of admission and a composite measure of treatment failure, again defined similarly, late intubation, death, or readmission. And of the 85,000 patients that were included in the study, about 79% of them were started on antibiotics at the time of admission, and 21% were not. Treated patients had a lower risk of mechanical ventilation after the second day, death, and the composite measure of treatment failure. And not surprisingly, they had a somewhat higher risk of C. diff. And you can see that here in a series of analyses, both unadjusted, covariate adjusted, propensity adjusted, and an instrumental variable analysis. And what was interesting was that in subgroups that were stratified by the predicted probability of the treatment of treatment failure, there was a suggestion down here that perhaps patients with the highest risk of treatment failure perhaps had slightly more benefit than patients with the lowest risk of treatment failure. But otherwise, we weren't really able to detect any significant heterogeneity, for example, around whether patients had sputum testing performed. And you can see, based on the confidence intervals in the subgroup who had sputum testing, that sputum testing wasn't routinely done in this cohort. All right, so let's turn back to this case. On the day after admission, the patient is more hypoxic, confused. She's using accessory muscles of respiration and is placed on high-flow oxygen. But little improvement is noted, and 10 minutes later, her ABG is 725, 60, 85 with a bicarb of 32. So show of hands, how many people plan to now increase her steroids to 125 milligrams and monitor? B, start a trial of non-invasive ventilation. Some hands go up. C, intubate and begin invasive mechanical ventilation. A and D, A and B. That would be increase steroids and put over on non-invasive ventilation. A couple more hands go up. Or A and C, increase the steroids and intubate. Right, there's not a lot of certainty in this audience about what to do here, clearly. Either that or you're just getting bored with audience participation. And my colleague said, you got to make sure you put in audience response questions into this talk. Okay, so the guideline recommendations here say that non-invasive ventilation improves respiratory acidosis, what we were seeing in that case, decreases respiratory rate, severity of breathlessness, and complications such as VAP and length of stay. More importantly, mortality and intubation rates are reduced by this intervention. Both of these are level A evidence ratings. And knowledge about the effects of non-invasive ventilation come from at least a dozen well-done RCTs carried out in the 1990s and early 2000s. And as you can see here, the pooled estimate suggests a reduction in the need for intubation of about 65%. The impact on short-term mortality is almost equally impressive. The idea here, as sort of highlighted in the guideline recommendation, is that the mortality benefit is primarily driven by avoiding the risks associated with invasive ventilation, barotrauma, ventilator-associated pneumonia, venous thromboembolism. And one thing that's worth noting is that this is a Class A evidence rating. There are a bunch of RCTs, but the total number of patients who've ever been randomized to the non-invasive arm in these trials numbers only a few hundred. And so we're not talking about, a level of sort of confidence that we have for some other interventions in medicine. So as I mentioned at the very outset, we have some funding from NHLBI to both examine the effectiveness of non-invasive ventilation in routine clinical practice, but also to look at its adoption across the country. And what we're particularly interested in is trying to learn about why some hospitals have been more successful at implementing non-invasive ventilation than others. As part of the grant, the first part was just looking at the effect of non-invasive ventilation in this large cohort, this large network. And so we assembled about 25,000 patients who all received some form of mechanical ventilation at the time of admission, either NIV or IMV. The exposure we were interested in, obviously, was the form of ventilation, and the outcomes were in-hospital mortality, hospital-acquired pneumonia, length of stay, costs. And in terms of the covariates that we had access to, the usual sort of demographics, comorbidities, some indicators of COPD severity, like how many times had they been hospitalized in the year prior, whether they had ever been intubated before, and other acute therapies, so steroids, antibiotics, other things that they got during the hospitalization. So what we found in this cohort of patients from like 2010, 2011, was that about 70% of them were initially treated with non-invasive ventilation. And overall, the NIV failure rate, that is the percent of patients who start on NIV that ultimately get placed on invasive ventilation, was about 15%. And as you can see here, we have a number of analytic models. That's the sort of the little letters here. Again, this is multivariable regression with propensity adjustment. And regardless of the analytic approach, what you're seeing is benefits on mortality that are somewhat attenuated relative to the estimates from the meta-analysis of the efficacy studies, but still quite impressive. We were also able to document a pretty marked reduction in hospital-acquired pneumonias. Now, these are a little bit difficult to measure using claims data, but taking advantage of present on admission indicators, we took a shot at that. We didn't see any effect on readmissions, and patients treated with non-invasive ventilation tended to have a shorter length of stay and lower cost, as you might imagine. I think one of the particularly interesting findings of this study is that in the subgroup of patients who had comorbid pneumonia, which accounted for about 20% of the sample, we weren't able to find any benefits associated with non-invasive treatment. And, I think that may be, our study wasn't designed to answer this, but in talking to some colleagues in pulmonary medicine and just thinking about this ourselves, non-invasive ventilation is particularly good when the condition is rapidly reversible. So a COPD exacerbation, sometimes heart failure, but a mnemonic consolidation process may be less amenable to this type of therapy. So coming back to our case, I think the trial of non-invasive ventilation, probably the right answer here. Should you increase the steroids in a patient who was just getting low doses of steroids? We don't have any evidence about that. I bet you it's done sometimes, but you're kind of on your own there. All right, so I've reviewed steroids, antibiotics, non-invasive ventilation. I think those are kind of the mainstays of therapy, but there are, of course, a number of other important elements of care. I'll get to some of these later, but obviously keeping in mind supplemental oxygen and short-acting bronchodilators, thinking about the person's home regimen, inhaler education, smoking cessation, asking about depression and anxiety, which is very highly prevalent in patients with COPD, referral to pulmonary rehab, and end-of-life care discussions are also important elements of the sort of the hospital care. All right, so as I said, COPD has gotten kind of a short shrift when it comes to being studied and being the focus of quality improvement activities, but we are beginning to get a handle on some of the opportunities to improve care. So the first study to really focus on this, on hospitalized patients, was this paper that we published in the Annals back in 2006. And this was a hospital-level analysis, so this isn't patient-level data. We were working with patient-level data, but what you see here on the y-axis is the percent of patients who received treatment at different hospitals. And here on the x-axis, you see a bunch of different treatments for patients. And we used the ACP guidelines at the time we did this study to categorize treatments into this group of beneficial therapies, so oxygen, bronchodilators, steroids, antibiotics, chest radiography, blood gas, and non-invasive ventilation. Non-beneficial therapies, sputum studies, acute spirometry, theophylline, chest physiotherapy. And then we took the concept that IHI had developed around sort of a bundle and said, did you get recommended care? That would be all of the recommended therapies. All of the recommended therapies. Or non-recommended care, that would be any of the non-recommended therapies, or ideal care, which was all of the recommended therapies, none of the non-recommended therapies. And what you can see here is that, for some things like bronchodilators and chest radiography, at the hospital level, virtually all of the patients get these interventions. When you're talking about steroids and antibiotics, the median hospital gave these treatments to 85% or so. But there were some hospitals where the treatment rates were lower down here, in the 70% range. And for something like arterial blood gas, this, there was dramatic variation where some hospitals seemed to be doing a blood gas on just about every patient who was hospitalized, and others rarely did it. And then, you can see somewhat more variation for some of the non-beneficial therapies, perhaps reflecting the less certainty about the evidence there. And once you put these together into composite measures, you also see quite a bit of variation. And this ideal care measure, only about 40% of the patients at the average hospital was getting what we could count as ideal care. So the studies have gotten better since that first one that we did, which was kind of at a high level. And Ann Meltzer and David O. and colleagues here at the University of Washington published this interesting paper in 2012 in which they looked at how well we're doing at preventing future exacerbations. So we know from some well-done efficacy studies that long-acting beta agonists and inhaled corticosteroids can reduce the risk of exacerbations. And they assembled a group of nearly 50,000 patients with COPD within the VA, VISN 20 here, and identified almost 3,000 exacerbations, both inpatient and outpatient exacerbations. And they looked at whether medications were added to prevent exacerbations, to prevent future exacerbations over the subsequent 6 months. And what they reported was that only a third of the patients actually following an exacerbation got started on a LABA or an inhaled steroid. And there's some limitations of the study. It's possible that some of the vets went and got their medications elsewhere or had treatments elsewhere. But, usually they come to the VA for their medicines. That's like one of the great benefits. So this is, I think, very interesting. They also found that there were some risk factors for not getting additional treatment, and this included older age, being a smoker, prior COPD exacerbations, depression, and diabetes. And these risk factors seem to be independent of whether the patient was an inpatient or outpatient. So another important issue when we're thinking about preventing future exacerbations is medication adherence. And unfortunately, we know that medications dispensed via respiratory inhalers can be difficult for patients to use. So in this study, Valerie Press and colleagues at the University of Chicago looked at 100 patients with obstructive lung disease, COPD, and asthma who were hospitalized at the University of Chicago. And they broke down the correct steps, the correct use of the MDI and discus device into between 10 and 12 steps. And they said that if you didn't get at least 75% of the steps right, that constituted sort of misuse of your inhaler. And what they found was that misuse of the inhalers was the norm. 86% of the time, patients were not able to use the MDIs right, and 71% of the time, they weren't getting the discus device to work properly. And poor vision, low health literacy were associated with worse performance using these inhalers, and were also more common in COPD than among the asthma patients. So we talked about non-invasive ventilation earlier, and we're just beginning to get a picture of the adoption of non-invasive ventilation into routine clinical practice. we got scooped by Chandra, who published this paper in the Blue Journal in 2012, in which they showed that between 1998 and 2008, this was using the nationwide inpatient sample, that use of non-invasive ventilation increased about fivefold in the United States. There was also, as you can see here, a concomitant decline in use of invasive ventilation, although total ventilation rates actually went up. It wasn't an entirely sort of one-to-one offset. I mentioned earlier that we've been looking at the use of non-invasive ventilation in this grant, and this figure shows risk-standardized percentage of patients who of ventilator starts that are non-invasive at the hospital level. So on the x-axis, you see the risk-standardized NIV percentage. So that's the percentage of all ventilator starts that are non-invasive within a hospital. And then on the y-axis, the percentage of hospitals in our sample. And you can see here that the modal rate is somewhere just below 80% of ventilator starts. But we have almost a third of the hospitals, or a quarter to a third of the hospitals in our sample, where less than 50% of the ventilator starts are non-invasive. So what we're interested in this grant is trying to figure out the strategies that these hospitals on the right side of this distribution curve are doing that might be portable to the hospitals on the left side. Now, of course, I can't tell you from this figure what the optimal NIV rate is. I can tell you that we have done some analyses that say as the NIV proportion increases, the rate of NIV failure doesn't seem to increase much at all. And in the hospitals in the highest quartile of NIV proportion, they have the lowest rates of invasive ventilation and only modestly higher rates of total ventilation. So within our sample, we haven't really been able to sort of see what that upper threshold is. We haven't looked at sort of individual hospital outliers. But these are some interesting preliminary data. We haven't published these yet. So another potential sort of quality opportunity in COPD, I think, has to do with dyspnea. And you guys can appreciate that dyspnea is really the primary reason that patients get hospitalized for COPD and also for things like heart failure, asthma, and pneumonia. And we recently wrapped up a study in which we looked at levels of agreement between physicians and nurses as it related to dyspnea. So we assessed dyspnea severity in 150 patients who were admitted with COPD, heart failure, pneumonia to our medical service. We had a research assistant go and every day ask the patient using a 10-point numeric rating scale to tell us their level of dyspnea severity. And then we also asked the patient's nurse and the patient's doctor for them to give us their assessment of the level of dyspnea. And what you can see here is that, well, first of all, that physicians and to a lesser extent nurses tended to underestimate the self-reported dyspnea severity level of the patients. And the level of agreement was really quite poor, as reflected in these kappa statistics of 0.24 for the physicians, for the nurses, and 0.16 for the physicians. And there was agreement within 2 points on this 10-point scale in less than 40% of the times that we asked. So the other thing that we found was that dyspnea severity, that there's quite a bit of sort of dyspnea burden at the time of discharge. So on the day of discharge, a third of the patients reported moderate or severe levels of dyspnea, and something like 5 or 6% were in the severe category. So we're starting to look now at whether levels of dyspnea at discharge correlate with readmission rates, for example. But what I think is interesting to think about is whether, if physicians had a greater awareness of the dyspnea level of their patients, whether that might lead to changes in treatment that might ultimately improve the trajectory of resolution of dyspnea symptoms and improve outcomes. So stay tuned for that. That's a project that we're thinking about doing next. So just taking a step back from the trees to look at the forest, here are some data on hospital outcomes. As I mentioned at the beginning, together with David O, I've done some work for CMS measuring hospital outcomes. And what you see here is, again, on the y-axis, you've got the number of hospitals, and on the x-axis here, the 30-day risk standardized mortality rate for patients with COPD. And the national rate here is about 8%, but it ranges at some hospitals as low as 4%, and at others as high as 13%. We have no idea really why there's this much variation. What's responsible for it? Is it use of things like non-invasive ventilation? Does it have to do more with end-of-life care decision making that we can't measure here? But these are the kind of data that are going to start to be shared with hospitals that may stimulate quality improvement efforts and investigations into COPD that really haven't been going on before. The sample in this project, we also looked at readmission rates. So you can see overall, again, a national readmission rate for Medicare beneficiaries of around 21%, with hospital risk standardized rates varying almost twofold across the hospitals in the U.S., from 16 to 30%. All right, so in this last section of the talk, I'd like to share some novel strategies to improve hospital care. And I'm going to start off with this study by Ying Tabak, which was published in the archives a few years ago. And I think most of you are probably familiar with clinical prediction rules like the CURB 65 for pneumonia or the CHADS-2 score for patients with AFib. Taking advantage of a very rich clinical data set, Ying developed this model to predict intubation and mortality. And the study included 88,000 patients with COPD hospitalized mostly in Pennsylvania between 2004 and 2006. She used recursive partitioning methods to create these 5 risk classes. They had access to about 100 clinical variables to use in developing this model. And the 3 key predictive factors that they found was a BUN of greater than 25, which keeps showing up in every model that you can think of, whether it's pneumonia or acute pancreatitis, as incredibly predictive of bad outcomes. Altered mental status and tachycardia pulse of 110 or greater. And then age 65 or younger was an additional stratifier. So she called this the BAP 65. I don't think it's really caught on yet, but you guys could sort of be in the vanguard talking about the BAP 65, on rounds. But what she found was that, if you had all 3 risk factors, BUN, altered mental status, pulse greater than 109, your inpatient mortality rate, this isn't even 30 days, the inpatient mortality rate is 13%. If you had 2 risk factors, you're at 6%. No risk factors and age less than 66, a mortality of 0.3%. And this model had a reasonable C statistic of about 0.72 for mortality and 0.77 for mechanical ventilation. This might be useful then to identify patients who, like in our kind of initial case, might be better triaged to an intermediate care bed rather than a regular ward bed. So the second study I want to highlight addresses the issue of mainly about antibiotic stewardship. And we know from a lot of literature that as many as 50% of patients with COPD exacerbations, the infectious agent is probably viral, and antibiotics don't benefit. So even that study I showed you where we said, look, it looked like everybody who got treated with antibiotics benefited, we know that there's probably quite a bit of overuse of antibiotics there. But we don't really have a good way of differentiating who needs antibiotics or who doesn't. Procalcitonin is a peptide precursor of calcitonin that's released by parenchymal cells in response to bacterial toxins and leads to elevated levels in the setting of a bacterial infection. And it also seems to be downregulated in the face of viral infections. So this ProHOS study, which was published in JAMA in 2009, was another multi-center non-inferiority RCT. There were 6 sites. I think this was mainly done in Europe or exclusively in Europe. And it was 1,400 patients with lower respiratory tract infections. So it included cohorts with pneumonia, COPD, and other conditions. The intervention patients had antibiotics administered by this procalcitonin protocol, and overall they found a 35% reduction in the mean duration of antibiotics and 50% reduction amongst those with COPD. And you can see here, this is the figure of the cohort of 228 patients in the study with COPD, and the percent by day of study inclusion, the percent who were on antibiotics. And so you can see here that, beginning on day 0, we have quite a bit difference that increases over the first 3 to 5 days, showing that you can really substantially reduce antibiotics exposure without any added adverse events. And so the safety profile in these two groups was similar, and there were fewer antibiotic-associated AEs in the procalcitonin guided treatment arm. So, I think this has really important implications as it relates to things like C. diff that came up again in that first case, and could potentially have a lot of impact. So another interesting study was the follow-up study from the group at the University of Chicago. And, so I showed with you earlier that most patients are not able to use their inhalers correctly. This was a single-center RCT of 50 patients who were randomized to sort of conventional medication inhaler teaching versus a teach-to-goal approach. And Teach-Back has been used successfully in other settings. It's endorsed by the NQF, and basically the Teach-to-Goal group had written and verbal instructions followed by repeated demonstrations and Teach-Backs. So patients had to really be able to kind of demonstrate that they were able to use their medications, use the inhalers. And what you can see here is that the brief intervention, this is the usual care group, there was an improvement here. This is the percent of patients who didn't know how to use their inhalers. So this improved, but the improvement was much more marked in the teach-to-goal patients. And so I think this is again something that we might want to consider for hospitalized patients, given how important these medications are for the long-term management of folks. So another topic I want you to think about is the role of pulmonary rehab after discharge. So we know that pulmonary rehab is associated with improvements in quality of life for patients, and this is something that gets another evidence level A recommendation in GOLD guidelines. But I don't think we've historically tended to think about referring patients to pulmonary rehab immediately after discharge from a hospitalization or immediately following an exacerbation of COPD. But there's actually some evidence from a couple of studies in England that this might not be a bad idea. So the first study was a single-center RCT, a small number of patients, but they started an 8-week pulmonary rehab program within 10 days of hospital discharge. And they demonstrated that intervention patients had clinically significant improvements in walking distance and in respiratory symptoms, with a 13-point reduction in the St. George Respiratory Questionnaire, without any increase, again, in adverse events. And just this year, there was a study published from Leicester, England, of 160 patients. This was really more of a case series in which, within 4 weeks of hospital discharge, they started a 7-week program. The patients were 70 years of age on average, FEV1 of 1. And patients showed improved walking distance and functional outcomes. And they reported lower rates of hospital readmission compared to the year prior to the index admission. And, this isn't the strongest study design, but I think what you're seeing here is that there's some feasibility, and the patients seem to be getting the benefit of pulmonary rehab without adverse consequences. This may be something that, as hospitals are trying to think about what do I do for reducing readmissions, that they ought to be looking into. So now, if you take smoking cessation counseling, that's something I haven't mentioned, pulmonary rehab, self-management, all patients, right, need some self-management education, inhaler teaching, which we've talked about, and you put it, and an outpatient follow-up appointment, you put it all together, you have a COPD bundle, right? And we like bundles all over medicine now. Maybe they're passé almost at this point, but Hopkinson published this paper in 2012 in Thorax, in which they reported on implementation of a COPD bundle on a respiratory care ward at an English hospital. And using sort of a paper-based tool like this, basically, the implementation strategy was get people on the ward to check off these boxes, indicating that they had done it, and that was sort of the reminder system to make sure these elements of care were in place. And they reported really impressive improvements. I mean, I wish we could have this kind of success at our hospital in QI. Smoking cessation, 18 to 100%, pulmonary rehab referrals, quadrupled, self-management plans doubled, review of inhaler technique. I mean, you could say that care was really crappy sort of in the pre-period, or that this was just a really effective strategy, or maybe it was both. And they also reported the change in readmission rates amongst the patients over this time period. It's a sample of only 94, but in the post period, but you can see what certainly looks like a trend towards better readmission rates related to the bundle. Okay, so this is the last case. Your patient has improved clinically. You guys made all the right decisions about what to do, and is now ready for discharge. On rounds, the third-year medical student asks if she should be referred to the hospital's new COPD care management program. So you respond that COPD care management programs, A, are effective at preventing readmission, show of hands. B, are not effective at preventing readmissions. C, have been shown to increase the risk of death. Or D, all of the above. All right, it's a very savvy, test-taking audience. You probably didn't even know it. You just sort of guessed that this was the case. So with apologies to Dickens, let me tell you a tale of two care management studies. The first study, entitled Integrated Care Prevents Hospitalizations for Exacerbations of COPD Patients, was published in the European Respiratory Journal a few years ago. It was carried out in Spain and Belgium, and it was 155 patients who were randomized after hospital discharge to the following multi-component intervention. They had an in-depth biopsychosocial assessment. That sounds good. They had self-management training at discharge. That is something we talked about before. They received an individually tailored care plan between the specialized nurse case manager assigned to them and the primary team. And it was agreed upon and sort of signed in blood and distributed. And there was accessibility of this specialized nurse through a web-based call center with proactive reaching out to patients, but also patients were able to contact them. And what they showed was that readmission rates fell from 69% in the group randomized to usual care versus 51% at 1 year. So, one thing to highlight here is, look, I've been reporting on like 30-day readmission rates. Look at how bad the readmission rates are over the course of a year. I don't know if that parallels our own Medicare data or if it reflects a European experience, but I don't think our data are that far off, truthfully. And there was no difference in mortality, but very significant improvements in hospital readmissions. The second study published by Vincent Fan here reported on what was ostensibly a somewhat similar intervention, at least to sort of an external reader, journal reader like me, that was carried out at the VA. This was a randomized trial of what they called comprehensive care management program at 20 VAs with 426 patients out of a planned 960. And what their intervention was described at was a series of 4 one-on-one COPD education sessions, a group education session, action plans for exacerbations, and scheduled telephone calls with study nurses, with care management nurses. And some of you may be familiar with this study. This was stopped prematurely for safety concerns when there was increased risk of death, all cause, and deaths due to COPD in the intervention arm with no effect on hospitalizations. And I think there were a lot of questions at the end of the study about sort of what went wrong, and I'm not really prepared to get into the details of it here, and I don't really know them, but I think what I take away from looking at these two studies is, there's a a lot sort of under the hood, and the devil is probably in the details about how these programs are set up. And so just saying you've got a readmission reduction program or a care management program, there's probably quite a bit of heterogeneity, and you need to look at what you're getting into. So you got this question right. So I'm going to just try to sum up now what I think are some of the key points. In thinking about the changes you can make in your practice, I would say, consider the use of risk stratification using this BAP 65, mainly to think about who should be at an intermediate level of care. It's not going to be sufficient to get our ICU attendings to admit somebody just because they have a 13% chance of intubation, but I think you might be able to argue for an intermediate care bed. Obviously non-invasive ventilation for patients with acute respiratory failure is the standard of care unless they have serious contraindications. You guys already know that you should be using short courses of low-dose PO steroids. I hope I've maybe planted a seed that maybe we should be asking more routinely about the level of dyspnea of our patients. There's definitely some opportunities to optimize home regimens prior to discharge. So that would be adding a long-acting beta agonist, an inhaled corticosteroids, or perhaps triple therapy, a LAMA, a LABA, and an inhaled steroid. And refer more patients to pulmonary rehab and think about doing it right at discharge. And then at the system level, there are some things you can do yourself, and there are some things that you need to enlist help in. And I think at the system level, there are some opportunities for protocolization of care around, identifying who are good candidates for non-invasive ventilation. You can't just start ordering procalcitonin unless your lab offers it, or you've got a protocol for how to use the data. Consider changing the approach to inhaler teaching to use one of these teach-back methods, a teach-to-goal strategy. And, I think if your hospital is interested in readmission for COPD, you might think about developing and implementing a discharge bundle along the lines of the one that I shared with you. So just to close, COPD exacerbations are common, they're costly, they adversely affect disease trajectory and quality of life. There are effective therapies to treat exacerbations and to prevent future ones, but as I think I've shown you, they're not reliably delivered. And although it's long been neglected, COPD is beginning to receive increased attention from hospital leaders and policymakers. And I hope I've given you some reasons to be optimistic that there are new strategies poised to improve patient outcomes. So let me just acknowledge some of my colleagues at Bay State, at the Cleveland Clinic, at Tufts, and UMass, and the staff within our center. And I'll leave you on this happy note of what I'm flying back to in Massachusetts this weekend. So thanks very much for your attention.